Dean, School of Health Sciences, Dr. Asma. IGMH Pediatric Cardiologist, Dr. Aishat Elena. Chairperson of Tiny Hearts, Dr. Asil Jalil. Students of Villa College and respective attendees. Tiny Hearts team, and people channeling in to watch this live session. Assalamu alaikum. It is my pleasure and honor to welcome you all to this session on understanding congenital heart disease. This session is being organized to mark the International CHD Awareness Week, marked worldwide from 7th to 14th February every year. During my pregnancy, like most expecting mothers, I also read the book, What to Expect When You Are Expecting. I distinctly remember skipping the page on birth defects, thinking I would not need to know this. But on the 4th day of my son's time in this world, we learned of the condition congenital heart diseases. Interestingly, it was a nurse who first identified that there was something worrying. It was Sister Shimana who took Kian for a bath and rushed to our room to ask if he was doing well. She asked if he was able to feed or if he was able to sleep all night, and she asked us all the correct questions that needed to be asked. Then she told us that she noticed that he was not responding normal during the bath time, such as crying, and he had his eyes wide open with minimal movements. His nails and lips were sort of blue, so she rushed him to check his saturation, which turns out to be at 50, SpO2 at 50. And that was the turning point for us and Kian. This is a statement to the important and influential role of nurses when it comes to CHD, and especially timely intervention and identification. My personal experiences and all the stories we have heard from CHD families and health professionals prompted us to this very special session taking place here today. We are extremely thankful for Villa College for facilitating this opportunity for Tiny Hearts of Maldives to help empower nurses to save and change lives of CHD warriors and their families. Once again, let me extend my warm, hearty welcome to you all.
Thank you, Hishko. Next on the agenda is THM statement on CHD Awareness Week. This number will be presented by Dr. Muhammad Asil Jalil, Chairperson of Tiny Hearts. Dr. Muhammad Asil Jalil.
As I read the statement, I would like my office bearers to line up with me. Kindly come up. Thank you. Guest of Honor, State Minister of Health, Dr. Shah Ismail, Rector of Villa College, Dr. Ahmad Anwar, Dean, School of Health Sciences, Dr. Ashma, IGMH Pediatric Cardiologist, Dr. Aishat Elena, students of Villa College and respective attendees, and people channeling in to watch this live session. Thank you very much for joining us. Before I read out the statement, I would like to express my gratitude to our guest of honor, Dr. Shah Ismail, who is here after a very busy day. Despite being the busy day, I think it just shows his fondness to promote preventive health. And I'm also very pleased to note that my then headmaster, Dr. Ahmad Anwar, is here today. I think even after 20 years, he's driving everyone to teach, learn, and make sure people are empowered. I think he truly deserves an applause. Let's give him a big applause. I thank Dr. Ashma, a very close friend of mine and colleague, who has taken up to teaching nurses and is heading the as the Dean of School of Health Sciences today. I think it's a very auspicious time that we are joining hands to make sure correct information are passed to the right people. Thank you very much. I would like to read the statement now. Mali City, 10th February 2019, Republic of Maldives. Congenital Heart Disease Awareness Week, marked from 17th to 14th, is an annual international observance to promote awareness and educate about CHDs. CHD is the most common birth defect globally and in the Maldives. In many cases, heart defects are easily correctable or may not even require further intervention. However, in serious or in babies born with critical congenital heart disease, the heart defect can be life-threatening and require immediate medical attention. If delayed, these babies may suffer irreversible damage to the brain and other vital organs that can negatively impact their potential in life. We care about the people born with CHDs every day of the year, but this is a very special opportunity to celebrate them. This is the 4th consecutive year that THM is marking this day. We remain committed to this observance, as an estimated 1 in 100 children born are with CHD in the Maldives. Today, 550 patients with CHD are registered with Tiny Hearts Maldives, of which 98% of children are under the age of 10 years. THM is resolved to using the strong platform provided for our work nationally and globally to advocate for the alignment of state health priorities pertaining to CHDs in line with that of international best practices, specifically to strengthen systems and processes that generate appropriate statistics on CHDs. Secondly, work in partnership with stakeholders to address policy and service gaps in responding to prevention, early detection, and treatment of CHDs. We are committed to help strengthen the implementation of national protocol for screening of critical congenital heart disease in newborns by the pulse oximetry launched in 2018, which would help detect a considerable percentage of newborns with heart defects, particularly those with critical congenital heart disease, for whom early intervention is vital. We are also committed to raise awareness among expecting mothers to address factors contributing to heart health so that each pregnancy has a healthy outcome. We are grateful that medical advances have followed many of the patients to soldier past childhood to near normal adulthood. We encourage every child born with CHDs to be registered with us so that we can strengthen continued care as well as advocate for stronger mechanism of CHDs nationally. Hence, we call upon the state, partners and stakeholders and individuals to come together more strongly in concerted endeavors to help prevent the loss of lives to CHDs and ensure healthy, safe, productive and happy lives for all. We are CHD aware and are committed to make the population CHD aware. Thank you very much. Before I end, I would like to express my gratitude to Dr. Elena, who has always participated in our CHD Awareness Week. She is the sole pediatric cardiologist in the Maldives, and we would like everyone to be familiar with her face, name, places, and the advice that she has to give us. Thank you very much.
Thank you, Dr. Asil and team. Next on the agenda is the information session by Dr. Aishat Elena, pediatric cardiologist of IGMH. Dr. Aishat Elena.
use the mic. Okay. Yeah. So today, in the next 30 minutes, we'll try and understand what a congenital heart disease is. So this is a very close topic to my heart too, as a pediatric cardiologist. So what is it? So congenital heart disease, it's one or more abnormalities in your heart structure that you are born with. So you have it when the baby is born, so you don't acquire it later. So these congenital heart diseases, they can be simple and which do not need any treatment. And they can be more complex, which requires several surgeries performed over a period of several years. I made it very simple because we've got nurses and some of the students too here, so that it's easier for us to understand what it is. When we look at why do we have congenital heart disease? In majority of the cases, we don't know why we have congenital heart disease. In some of the cases, there are many reasons why the child has congenital heart disease. Like in some cases, like in chromosomal or genetic anomalies, if the baby has, there is around 10 to 15% chance of the baby having a congenital heart disease. Trisomy 13, 18, 21, these are some of the genetic disorders that we have in our population too. Down syndrome, trisomy 21, we have a lot of kids with Down syndrome. Majority of them, they have congenital heart disease. You can say almost half of the Down syndrome babies are born with congenital heart disease. And out of the babies who has congenital heart disease in Down syndrome, there's a condition called AV septal defect. So majority of the babies with Down syndrome, they have a condition called AV septal defect. I'll explain to you shortly what AV septal defect is. Some other maternal or environmental factors play a role, like some of the maternal drugs that the mother might be using during pregnancy will lead to congenital heart diseases, like if the mother is taking alcohol, it has a high risk for the baby having congenital heart disease. Or if the mother suffers some of the infections, right, congenital rubella syndrome, in the first 7 weeks of pregnancy, there's a 50% chance that the baby will have congenital heart disease again. Some other infections like toxoplasmosis, we have it very prevalent in our community because of cats actually. And cytomegaloviral infections during pregnancy, all of these can lead to the baby having congenital heart disease. And gestational diabetes actually. I always tell Dr. Asil that we have a lot of gestational diabetes here. He always addresses it. It takes an importance to address it. And in IGMH, we have made it like all the babies who are born to a mother with gestational diabetes, we screen all the babies to rule out that they have congenital heart disease or not, so that we don't miss any of the babies before they go home. Some of the drugs that the mother might be using, like teratogens, like phenobarbital, warfarin, or chemotherapy, they can all lead to congenital heart disease again. So we know a lot of causes. The incidence, we've already come to it. It's 10 per 1,000 live births. When we look at our data that I've collected during my work here, it's a bit higher, maybe because I work in the tertiary hospital, main hospital here, and being an only person, we get all the referrals to IGMH. Maybe because of that, we have around much higher than the 10 per 1,000 live births in Maldives. And about 2/3 of these babies who are born with congenital heart disease, they are symptomatic in the first year of life usually. So during the first year of life, they have some symptom and they come to you within the first year. And this is actually a major cause of death. So we should know that prematurity in our population, because we are developed place in the mortality and morbidity, we should say. So prematurity is one of the commonest cause of death in the first year of life. And then another is this congenital heart disease. So this becomes actually very, very important for us to understand. The most common congenital heart disease, it's called a ventricular septal defect. And our data shows that we also have a lot of ventricular septal defects in Maldives, which I'll come to the data that I've collected. And 28% of the kids with congenital heart disease, they have another recognized anomaly, like the trisomies that I've mentioned just now. So this is the data that has been published actually. This is from the birth defect database from 2016 to 2017 end. So this is 2 years data. And from this even we can see that here in the blue one here, it's a circulatory system. So this is the portion of congenital heart disease. So this is a major birth defect in Maldives. So we should know that. Followed by the musculoskeletal system. So almost 1/4 of our birth defects is because of congenital heart disease. So when we go to the understanding congenital heart disease, we have to understand the normal heart first. I've put a very, very simple diagram here for you to understand. All the deoxygenated blood, which is used up from our body, they come through the SVC, the IVC, to the right side of the heart, the right atrium, goes through the tricuspid valve to the right ventricle, and then goes to the pulmonary artery through the pulmonary valve. So then it bifurcates on the two sides. So this is the right pulmonary artery and the left pulmonary artery, and it goes to the lungs, where the blood gets oxygenated, and it has to come back to the left side of the heart through the pulmonary veins here. So it comes to the left side of the heart, through the mitral valve, it goes to the left ventricle, and then it is pumped out through the aortic valve, to the aorta, to the whole body. So heart is a pump actually. So it takes up all the deoxygenated blood, sends it to the lungs, get it oxygenated, brings it back to the heart, and then pumps it back to our body. So this is a simple, very, very simple diagram of how the heart works. So for us to understand congenital heart disease, we need to understand that simple diagram. So congenital heart diseases, we can divide it into the acyanotic and the cyanotic heart diseases. Just now we've heard from HISCO that was a cyanotic congenital heart disease, which has actually made us come together here today. So we have the cyanotic congenital heart disease and the acyanotic ones. In the cyanotic ones, we can divide it into two hands again, the ones with the decreased pulmonary blood flow and ones with increased pulmonary blood flow. That is how much blood is pumped to the heart, to the lungs. The acyanotic ones, I've made it easier, the left to right shunts and the obstructive lesions. So it's commonly divided into the acyanotic and the cyanotic. The common ones I've just labeled for you to understand the names. So in the acyanotic ones, we have the left to right shunts. The VSTs, I've told you that it is the most common form of heart disease, followed by the PDA and the ASDs. And the outflow tract obstructions. So those are the main valves. If it is obstructed, that is called the outflow tract obstruction. So it can either be the pulmonary artery, which is narrowed, or the aortic stenosis, or a coarctation of the aorta. In the cyanotic heart diseases, we have different names like the tetralogy of Fallot, transposition of the great arteries, or the TGAs, AV septal defects, and many others, which we will discuss briefly. So in cardiology, we divide the heart again into the right heart and left heart for us to understand it easier. So what is the right heart? Right heart is all the diseases, like any disease which affects the right side of the heart, we call it the right heart diseases. So any disease which affects the left side of the heart, we call it the left heart diseases. So like in the left to right shunt lesions, the right-hearted lesions are the ASD. I'll come to it, what an ASD is. And the left-sided diseases are the VSD and the PDA. And of course, the obstructive lesions. On the right side, we have the pulmonary artery. So that is the PS. And on the left side, we have the aorta. So that is the AS and the coarctation of the aorta. So these acyanotic heart diseases are the less serious congenital heart defects, actually. They are usually not diagnosed until later in childhood because the child is very well. The parents doesn't notice any problem. The child will be playing, running, jumping, just like another kid. So when you look at him, he doesn't have any difference from the other normal kids. So how do we know it? It's usually by an incidental finding. So majority of the patients who are referred to me, it's because they go with a cold or cough to the emergency or the pediatrician who hears an abnormal sound in the heart, which is called a heart murmur. due to which he's been sent for evaluation. But the child looks very, very well. But if the lesions are big, they can come with heart failure too. So those children can present to you a bit earlier, maybe in the second month or third month of life. So, sometimes the teachers actually notice these children. So during PE classes, they're not being able to perform as well as the other children. So they might tell the parents that he's not being able to play for a long time. He sits down after a while. So they become tired. So the teachers are many of the times the teachers have noticed congenital heart disease or the fatigability, due to which the child is referred for an evaluation. And sometimes they can be fainting during exercise or activity, and then in severe cases there can be swelling in the hands, ankles, or feet. But majority of the cases they look very, very normal. If you remember this diagram, you'll remember the severe cases, how they present. So it's a small baby who comes with respiratory distress. So there'll be very fast breathing. They can be intercostal indrawing. So the rib cage where it goes down, or there can be sternal recession. The child might be having flaring of the LRNASI. And the mother would be saying that the child stops, take breaks during feeding, that he's not being able to take breast milk maybe, or he stops the bottle in between and again restarts to take it. There can be poor weight gain actually. The baby looks very, very cachectic usually. So the atrial septal defect, I made it very, very simple with only one diagram. So what is atrial septal defect? So I've explained how the heart is. So there is the right side of the heart, which has the deoxygenated blood, the left side of the heart, which has the oxygenated blood, and there is a septum actually, which prevents the oxygenated and the deoxygenated blood from mixing up. So the upper part of the two atria, the wall in between, that is called the atrial septum. So if there is a hole there, that's called an atrial septal defect. So how does these babies present? AST is the message that I want to tell you, that you'll see it often in echocardiography reports, but these are not serious congenital heart defects, I would say. If the defect is less than 8 millimeters, the norm is it closes spontaneously. So you don't need to be scared about that. We just do a regular follow-up, and like you said, 99% of the cases, it closes. But if the defect is bigger, are we worried? Still, we're not worried, because an ASD never goes into heart failure. So that is a message that you as nurses should understand that. Though there is a hole in the heart, the baby doesn't go into failure. So when is it that the ASDs become dangerous? So around 20 years of age, maybe, or 25 years of age. So that is when the ASD is present actually. So it's the adult cardiologist who detects majority of the ASDs. It's just an incidental finding that we pediatric cardiologists detect the ASDs, because they are sent for something else, and during an echocardiographic report, you always find a ASD. So they are not dangerous heart defects. But of course, we follow them up until like 5 years. So if it doesn't close by 5 years, we have to go for a closure in these cases, and we don't wait until 20 or 30 years, because that will be too late. So if it doesn't close by 5 years, usually it doesn't close. Then comes the ventricular septal defects. So what is it? It becomes very simple. The lower part of the septum, so this wall, so that is the wall between the two ventricles. So there is a hole in the wall between the two ventricles. So that is called a ventricular septal defect. So it's very, very simple. So what happened in these cases? So these children actually, it depends how big the hole is actually and where the hole is. So if the hole is down there in the muscular part, the norm is if it is small, it will close again. So it's again not dangerous if the muscular VST is there and if it is not big. So you don't have to be worried. But of course, if the hole is very big, the child can come with failure to thrive. So the baby will not be gaining weight. So when do these present actually? So VSTs, again, you have to know that as soon as when the baby is born, they would always be well. So the VSTs, even if it is big, they present at around 6 to 8 weeks of age only. So that is at 2 months of age, usually there will be difficulty in breathing or taking feeds, the baby is not gaining weight, due to which it might be brought. And if it is a small VSD, it again goes undetected. And during a cold or something, the doctor examines and hears a very loud murmur, due to which it comes to you. So these ones also we have to close, the bigger ones. So you might have to close a bit early, maybe less than 1 year sometimes, or within 5 years if the lesions are big. If not, if it is a muscular one, we just do regular follow-up, and then they will spontaneously usually close. When do we close? That is the thing the parents would be asking. We don't know. Sometimes within 1 year, sometimes within 5 years. But if it is getting smaller, you don't need to do anything with it. Then we have the PDA. So what's a PDA? I've already told we have 2 main great arteries in the heart. So that is the pulmonary artery and the aorta. And there is a connection between the pulmonary artery and the aorta during the intrauterine life, which is needed for their survival intrauterine. But this communication closes by around usually 24 to 72 hours or within 3 months of life. So this, if it doesn't closes after birth, then that is called a patent ductus arteriosus. So in this, what happens again? If it is all babies, like if I do an echocardiography on day 1, we will be seeing a PDA. So that's not an abnormal finding actually, because it's gonna close. It's gonna close maybe if I do it next day, or maybe on day 3, the child will not be having a PDA. But of course, if it is a big PDA, the child can go into failure. It is similar to the VSD. The child presents around 6 weeks to 8 weeks, or around 2 months. So they can be again the same thing that I have showed you in the previous picture. They can be fast breathing, the baby might not be able to take feeds. In those cases, you need an urgent closure for the baby to grow up, to go further. If not, majority of the cases again, this closes. Then, so how do we manage the cyanotic heart diseases? So we restrict fluid, we have to give adequate calorie, and we have to maintain the hematocrit rate more than 35%. And medications like we give, if the lesions are big, we might have to use diuretics, inotropic drugs, or even vasodilators. Specific management, of course, depends on the underlying cause. Like here, I've shown an ASD actually. So there are devices that we can use, which I hope in the near future, when the new hospital comes up, I have a passion for it, and I actually miss doing it actually, because we don't have the facility here. But this can be done easily. We can close it without opening the heart. So we put a catheter in, and then put the device in the hole, and then let go. So this is the fluoroscopic image. So the delivery cable is here, the device is coming here into the hole. So this is how you would see it. It's not seen that nicely. So here it is, the device on a chest X-ray. So we can close the VSDs, the PDAs, and the ASDs using device closure. But some of them, you have to go for open heart surgery, depending on the size of the lesion or where it is actually. So like 100% of them, we don't go for a device closure. So depending on where and how big it is, the management is different for different cases. Now the obstructive lesions, pulmonary stenosis. Stenosis means small or narrowed actually. So here, pulmonary stenosis, what happens? There is an abnormality of the pulmonic valve. So that is the right-sided main valve, which pumps the blood to the lungs. So there is something wrong with the valve, or there is something wrong below the valve or above the valve. So that is the pulmonary stenosis. Pulmonary stenosis, again, can be mild, moderate, or severe. Majority of the children, if it is mild, we don't need to do anything. If it is moderate or severe, you might have to go for some balloon dilatation or even surgery, depending on how bad the condition is. So that is also one of the congenital heart diseases. So on the left side, we have the aortic stenosis. So it's the same thing. The aortic valve gets narrowed. So this is the left-sided artery, which pumps the blood to the whole body. So this is the aortic valve. So if it is narrowed, it's called aortic stenosis. So this again can be like mild, moderate, or severe. So if it is severe, of course, the child would be needing a corrective surgery immediately after birth. But most of the cases, again, this goes undetected because it is mild. So again, because of incidental finding of murmur, the child is being picked up, and then we follow up regularly. And if it is not worsening, you don't have to do anything. If it is worsening, you might have to go for a balloon dilatation, or you might have to go for a surgery. Then there is a term called coarctation of aorta. So what is it? Coarctation of aorta, that means, so I've put the normal heart and the abnormal heart. So the aorta has to come up like this, like a nice, equally sized tube, which goes down to the descending aorta and abdominal aorta. So a coarctation is a narrowed portion of the aorta. Usually after the third branch it occurs. So the aorta gives certain branches, and then after that there's a narrowing. So what happens if there is a narrowing in the aorta? The heart would have difficulty pumping it. Like it's something like if you pull something out from a small straw, you have to pull with a higher pressure. The same way, the heart has to work very, very hard to pump the blood out of the body. So in this is again, if it is very, very narrow, you need an immediate emergency surgery. Otherwise, if it is just a mild coarctation, we can follow up. Majority of the cases, if it is a mild coarctation, it goes undetected till adult life even. And incidentally only it is found. But severe cases, of course, you would know immediately after birth. So the cyanotic congenital heart diseases, these are the serious ones that we have to give more importance to. So what are the serious congenital heart diseases? So these become usually evident soon after birth or during the first few months of life. So the signs are, Hishko noticed in her baby on day 4, 5, so there was pale gray or bluish skin. The nails, the lips can be blue. There can be rapid breathing. There can be swelling in the legs, abdominal areas, and around the eyes. And again, there can be fast breathing. The mother can come saying that my baby is not gaining weight. He's been having difficulty feeding since after a few days of life. So this is the typical history that she had. So the critical congenital heart diseases, what are they? We have names, different names, which sounds very, very scary sometimes. But these are, again, very easy. I made it very, very easy. So it can be the hypoplastic left heart syndrome, pulmonary atresia, tetralogy of Fallot, TGA, or the transposition of the great arteries, tricuspid atresia, truncus arteriosus, or TAPVCs. So what are these? We'll just look in one by one again. One slide for each. So I've started with atrioventricular septal defect because we have a lot of Down syndromes and we have a lot of AV septal defects. So what is AV septal defect? So if both the central part of the septum is missing, that's called an AV septal defect, as easy as that. So the atrial septum is missing and the ventricular septum is missing in the center. So there can be abnormalities of the valves too. How? Usually we have to have 2 AV valves. And but in these cases, there can be only single valve can be there. There can be regurgitation of the valves. So these children usually presents again around 1 month of age with failure to thrive, fast breathing. So the mother, so these children actually are well when you discharge them from the hospital. So just like Ishko, they'll be very happy. They'll be going home. After around a month or so, they'll come with all these difficulties. This is a condition that you need to correct within the first year of life. Majority of the cases, you need a surgery around 3 to 6 months of age. So you have to correct it early. If you don't correct it, you can never correct it. It is too late. So these conditions are important to know. Then there is a condition called tetralogy of Fallot. What is tetra? Tetra means 4. So in this condition, there are 4 things in the heart. So there is pulmonary stenosis. We already know what pulmonary stenosis is. So there's narrowing of the pulmonary artery. There is a large VSD. There is an overriding of the aorta. And there's ventricular hypertrophy. So these 4 components are there in a tough heart. So here you can see it very clearly. So the pulmonary valve, which is narrow, there's a large VSD. The right-sided wall of the heart, it's very thick. And then there is overriding of aorta. So how do these children present? So they can, again, have cyanosis or bluish discoloration. These children, if it is sometimes can go undetected, maybe around 2-3 years of age. The mother would come and say that my child sits down for some time, rests, and again gets up and walks. So that is like a clue to say that maybe he's having heart disease. So these children also go very, very well. So they look all well when they are born. So they go home very happy and then come back collapsed. So these are the conditions that we need to detect at birth. I'll come to it, how we're going to do it. Then there is the transposition of the great arteries. So what happens here? Again, very simple. So I put the normal heart here. So the normal heart, we know that the blue blood pumps through the pulmonary artery to the lungs, comes back, and the red blood is pumped out of the aorta. So what happens when this is reversed? So that is called the TGA. So here what happens is the blue blood comes into the right atrium, right ventricle, and then goes to the aorta. So is the child going to survive? No, all the deoxygenated blood is going to his body. So he's not going to survive. So how are these? So these is very important to detect like intrauterine or immediately after birth, because he's not going to live. He can live for a few days because there are certain holes in the heart that I've told you that a PDA is there and an AST is there or a PFO is there. So he can live for maybe around 2 days or 3 days, but usually they become symptomatic within 24 to 72 hours of life. That is 2 to 3 days of life. So this is very, very important, and if you don't do a surgery, of course he's going to die. And if you do a surgery, this is called an arterial switch operation. So what the surgeon does is, you have to cut it from here and then you switch it. So you switch it to the correct position. And they have a lifespan of a normal, healthy adult actually. So 70 to 80 years, they say. So we should not miss these children. We have to give them a life. We have to give them a chance to live, because these are easily correctable conditions if you can detect it on time. So it's very, very important to detect it. Then there is a very scary kind of name, total anomalous pulmonary venous drainage, but it's again easy, very, very simple. So I'll put the normal heart here again. So the normal heart again, first the blue blood comes here, goes back, goes through the pulmonary artery, goes to the lungs, takes up oxygen, has to come back to the left heart through the pulmonary veins, and then goes through the aorta. But in TAPVC, what happens? The blue blood comes in, goes to the pulmonary artery, takes up oxygen. So instead of coming to the left atrium, it is connected abnormally again to the right side. So what happens? The oxygenated blood again comes back to the right side of the heart. So the left side of the heart doesn't get any blood. So these children again needs to be detected early. How do they live? So you'll be thinking, so there is no blood coming to the left side of the heart. So how do they survive? They survive because of the atrial septal defect, which is there in all the babies when they're born. But again, this closes around 2 to 3 days of life usually, or within 3 months maximally. And the PDA doesn't help much, but that can help for a few days. And this is very, very important to detect too, and this is easily detectable. As nurses, you can make a lot of difference. That is what I wanted to stress here today. So this is one of the cases that I have just 2-3 days back. It's a case of TAPVC. I think you will have to press it. Yeah, okay. Yeah, thanks, Ma. So here I have put the normal heart for you to understand it better. So this is the right side of the heart. The tricuspid valve is here, and this is the left side of the heart. The mitral valve is here. It's pumping very nicely. So this is a normal newborn heart, beautifully here. So let's look at the difference here. What happens? So this is the right atrium, and this is right ventricle. The tricuspid valve is here. You can see the interventricular septum here. The atrial septum, which is pushed to the left side of the heart, actually. So the atrial septum is here, but it's been pushed to the left heart. Why is that? Here you can see the pulmonary veins nicely join into the left atrium. But here you don't have it. You don't have it. It's an empty thing here. So because of it, no blood is draining to the left side of the heart. So because of it, the left heart is not being able to perform well. So this is how you're going to see TAPVC like on echocardiography. In the 4-chamber view, this is how you're going to see it. I had this baby. I want to stress on this because we missed this baby. He was born in Addu, and then he was transferred in the middle of the night at 11 p.m. But at 62 days of life, actually. So he survived. He survived at 62 days of life. And then right now, he's been transferred today. He's waiting for his surgery tomorrow. So let's pray for him. Let's hope that everything goes well. So if this can be corrected, he will again have a beautifully normal life, a lifespan of around 70 years without any difficulties. So these kind of cases, we should not be missing it. The difficulty we have here is we don't have a cardiothoracic surgeon, so we have to fly these babies to Amrita, which is the institute that all our cardiac surgeries take place, the surgeon there. So I work as a part of Amrita team here. I hope that one day we will have the cardiothoracic setup here, and then we don't have to give like prostaglandin or like emergency drug, intubate the baby, embo him for 4 hours, and then again take an ambulance for another 6 hours and then transfer them. It's gonna damage their brains actually. So I hope that one day we can establish it here in Maldives, and then we can do these surgeries here. And I hope that I would be able to work better in the future. Then we have the double outlet right ventricle. These are complex cases. I've just put a diagram just to let you know that there is a condition called double outlet right ventricle also. The name tells you what it is. So there should be only one outlet from each side of the heart. The right heart has the pulmonary artery, and left heart has the aorta. So if both the outlets come from the right heart, that's called a double outlet right ventricle. So there is no outlet from the left side of the heart. So here again, the oxygenated and the deoxygenated blood mix, so the baby is going to be blue. So these conditions again need to be corrected according to how large the defect is, how big the pulmonary artery is, and many cases, but these are surgically correctable conditions and detectable conditions. The most important thing is that these are detectable conditions at birth. Then there is the pulmonary atresia. Whenever I see that, I always remember Hisko and Moi. Because we are here today because of them. Because of pulmonary atresia, I say that everything happens for a blessing. Sometimes you have to think like that, actually. So this, what happened? Pulmonary atresia, what happens here? So the pulmonary atresia, the pulmonary valve is not there, actually. So there is a very, very strong membrane or a sheath which is preventing the blood which is coming to the right heart to pump out. So there is no way the baby can get oxygenated blood because it is not going to the lungs. So there is no way he can live. So how does he live? So it is through the PDA. So just like she has told, they went home very, very happy because the PDA will be wide open at birth. So there will be mixing of blood. The baby doesn't have any symptoms usually until the PDA closes. So it is on day 3 that the PDA constricts or closes, and that is the time that they can't survive because they don't have the lifeline. So these children, they need prostaglandin. There is something called PGE1, which can open up the duct and keep it open. But it is very difficult. Our medical officers would know, our nurses would know how difficult it is to give PGE1 and to fly them off to Amrita. But these are correctable conditions only, and then they need immediate surgery. Immediate surgery, you have to open up the PDA, you have to stent it, and then give some time. So it's stage surgeries that they have to undergo. So initially, an emergency shunt will be done, a BT shunt it's called, and then you open the PDA by stenting, and then you let the baby grow, the pulmonary arteries will grow, and then you go for a second surgery. So these are stage surgeries, but they can be correctable depending on how the heart is formed. Then we have the tricuspid atresia. Here the tricuspid valve is missing. So that's again a very severe cyanotic heart disease child. I just wanted to mention the name. Then we also have the truncus arteriosus. What is truncus? We have 2 outlets in the heart, I've told you. So truncus is when there is only one outlet. So that means the pulmonary artery and the aorta, they merge. There is only one outlet. So what happens? Again, there's mixing of the blue and the red blood. So the baby is going to be blue. So this again has to be corrected early, within 3 months. Otherwise, you cannot correct it. So these are emergencies cases where you need the baby to be operated within 3 months of life. Then there is the Epstein anomaly. I put the normal heart for you to understand. So this is how beautiful it looks. And then what happens in Epstein anomaly? This valve has gone down. So that is what is an Epstein anomaly. Just want to know the names, because if I go into details, it becomes too long. Then there is a very, very scary condition I call, it's a hypoplastic left heart syndrome. Hypoplastic, that means it's not there, it's not formed. Okay, it's small. So what happens? Whole of the left heart is not formed. So it's very easy to understand. So that means the left atrium, left ventricle is not there, the mitral valve is atretic or very, very small, the whole of the aorta is very small, or it's not formed. So that is called a hypoplastic left heart syndrome. This is a very, very poor prognosis condition. Usually needs to be detected intrauterine if anything needs to be done, because they need immediate surgery, because they are again duct dependent, just like the pulmonary atresia. So if they're born and not detected, they'll succumb immediately, because when the duct closes, they can't live. Intrauterine, they don't have any difficulty because mother does everything for them. But once born, you have to do it alone. So you can't go on with life without surgery. And these children need lots of surgeries, actually, stage surgeries. It's difficult to, they have a very difficult life, I say. Even in the Western setups, even in the best centers, the lifespan is given around 20 years. But in our cases, we have 3 cases of hypoplastic left heart syndrome. I'm very happy to say that 3 of the kids, they're doing beautifully well. Operated at Amrita, they're doing very well. I always say that they're miracles, actually. One of them is 9 years now. Another is 3 years. They're doing very, very well, actually. So now let's look at the congenital. So all these names that I've told, how do we have that in our population? Do we have it in Maldives? I've collected some of the data since I've joined as a pediatric cardiologist in IGMH. So that I joined in 2015 August. So since till yesterday, I've compiled it last night. I thought I'll share the recent data with you. So till now, we have 1,000 cases of congenital heart disease registered in Maldives in IGMH, in our echo lab. So what are the cases that we have? We have lots of PDAs, 188 cases. We have VSTs, of course, 172 cases. We have ASTs, 261 cases. TOFs, we have 28 cases. Coarcts, 12. And TGAs, 21 are there. PAPVCs, 5. TAPVCs, we have 10. Cardiomyopathies are there. Complex heart disease are there. Like everything we have. Hypertrophic obstructive cardiomyopathy is there. Even cardiac tumors. When I started the presentation, the one that you saw, that's a cardiac tumor, which was detected last year, actually. The baby is doing beautifully well, actually. He's 7 months now. It's regressing. It's a rhabdomyosarcoma, and it's regressing nicely. The baby is happy to say that we don't need to do anything for the baby. He didn't need any surgeries. So that is how common congenital heart disease is in our society in Maldives. Now, how many new cases are detected each year? I've looked into that also. So in 2015, that is just from August, maybe that is why I just had 93 new cases. But in 2016, we had 237 new cases of congenital heart disease born. In 2017, we had 149 cases. Last year, we had 130 cases of new congenital heart disease born. And this year, it's just 1 month and 10 days. Today is 10th day. And this year, I've had 14 cases of congenital heart disease till now in my register. So that's a lot of congenital heart disease. And then you are the people who can make a difference. I'll tell you how you can make the difference. So and I've separated the 2018 cases because I was just collecting the data also. So last year we had 130 cases. So many of them were PDAs. We had a lot of ASTs. Of course, VST, we know that that's one of the commonest, the most common congenital heart disease. We had 27 cases. We had 7 cases of TOF last year. TGAs, 4 of them, beautifully doing, all survived very, very well. TOF, all are doing beautifully well. None of them passed away. TAPVCs, we had 1 case. The child is now was born in ADK, detected again at 62 days of life. And now gonna be 1 year, doing very well. Complex heart disease, we had 1 case. Pulmonary atresia, we had 3 cases. HOCM, we have 4 cases. This is the diabetic mother's children. We screened and we have detected 4 of them. Congenital MR, we had 1 complex heart, complete heart block. We had 1 case last year. The baby's been paced. Baby's doing well. He is now 4 months old, doing very well, and growing very, very well. Cardiac tumor was the one that I showed at the beginning of the presentation. So we had one case, a huge tumor. That baby is around 7 months now and then doing very well too. So in this year, what are the cases that we had? So we had PDAs, large PDAs, who one has been operated, two are waiting to be operated on congestive, like decongestions. VSTs, one has gone to Amrita right now for closure. ASTs, we have 4. Of course, we'll be following them up. We don't need to do it. AV septal defect, the baby's gonna be 3 months soon, so he will be sent for surgery. TAPVCs, one was the one that I've just shown, which was detected, and tomorrow going to be operated in Amrita. How come we have one? And a complete heart block. Again, there's another case actually. The baby is 2 months now. The heart rate is very good actually. We hope that and pray that the baby won't need pacing. It's around 65 to 75. So he's doing very well, and he's like feeding well. So there's no urgency to pace. So we have been following the kid. So these are the cases that we have till now, till today. So now is the most important thing. So how are we going to help them? Actually, how are you going to help them? How we as a team can help them? So this is the most important part of the presentation, I always say, by early detection. Because these children need to be detected early, because they can survive if we detect them, if we don't miss them, if we detect them before they go home. And there are tests like the pulse oximetry screening for the critical congenital heart disease. Meta-analysis has been done worldwide, many studies compiled, and then they have found that it has very high specificity of almost 100%, I say, 99.9%, sensitivity of 76%, and the false positive rate is very low. It's 0.14%. And this has been done all over the world, I say that. And then it was sad that, and it was very saddening when I came back from study that it was not done here, and then we were missing all these critical congenital heart disease babies. Tiny Hearts, of course, wanted to start it too, and we as a team is proud to say that we have started it in Maldives last year, a screening for this critical congenital heart disease. So we've done a screening algorithm, which you all need to understand, the most important bit of the presentation. It is a very easy test, a very simple test actually, which can be done. So how are we going to do it? We're going to just check the saturation of the baby on the right hand and one foot, either of the foot. And then let's say that the saturation comes less than 89%. Like in that TAPVC baby, if they have checked it in Nadu. The sad thing is that in the atoll hospitals or in the regional hospitals, we don't have saturation monitors, which is very, very sad in a place like Maldives, not being able to check saturation before you go home. But we do not have it. So the baby went home because 89% doesn't look cyanosed to the naked eye. So you have to detect it by pulse oximetry. So if it is 89% or lower, of course, that's a positive screening test. So you have to inform the pediatrician. So we have made it a protocol to inform the pediatrician then. And then we implement the follow-up protocol where physical examination would be done, and these babies will get a echocardiography before they go home. And then let's say that the saturation is 90 to 95. So it's not that bad. It's not normal either. It's low, but not that high to say it is normal. So in that case, what are you going to do? Or let's say that I got the right hand saturation as 90 and the foot saturation is 94. So it's not that bad. So in that cases, we're going to recheck the saturation after 1 hour, because many of the babies is going to have this. So you're just not going to do an echocardiography in all the babies who have a saturation of 92%. It's very, very difficult. So don't send all the babies. So we're going to check it again after 1 hour. And let's say that again, it comes as the same. Again, you're going to check it again. But in this case, you have to inform the shift in charge nurse, which will be one of you. And then you check it after 1 hour. And then, of course, if it is positive, you have to take the baby to the NICU and then, of course, implement the follow-up protocol, because something is really wrong with this baby. We have to see what is wrong. Or let's say that the difference is more than 3. What is the meaning of that? So let's say that on this hand, you got around 98. And then on the foot, you got 91. So there's a lot of difference there. Okay, so there is a difference of 7. So let's say that it is 98 here, and let's say the lower limb, you got 90. So a difference of 8. So if there is a more than 3% difference, that is again abnormal. So in these cases too, again, you have to follow the same protocol. You're gonna check it after 1 hour. Again, recheck it after 1 hour. If it is positive, you're gonna implement the protocol of screening the baby and examining the baby. Because of the PDA, many of the babies can have this limb, which can be normal actually, the baby can be normal. So that is the reason why we do it 3 times. And then this arm is the happy arm, I always call. The saturation is more than 95 in the right hand or right foot, and there is the difference is less than 3. So let's say that you got 100 here, and then you got 98 here. The baby is safe to go home. So we do this after 24 hours of life, because we wait for the PDA to close actually, so that you don't get false positive results so much. Because if you do it early, you're sure to get this. So we do it after 24 hours of life. So all the babies in IGMH, and we are very, very happy that with the help of our gynae team, and the Lira is here actually, said that all the babies get screened. We have not missed even one single critical congenital heart disease in IGMH since we have implemented this. So that's a very, very huge achievement, I would say that. And I think this can be achievable in all the islands too. We have, and which is what we have to aim for. And then also happy to note that we have launched the protocol also through the Ministry of Health, IGMH. And it was launched on the World Birth Defect Day, which was on March 2018, on 3rd March. And then I'm not sure whether it's published yet, but it was launched, and I'm not sure whether it's been sent to the islands. And I hope that it will be used in the islands, and then we will not be missing these TAPVCs or the TGAs from the island. We had a training too with many of the doctors and nurses involving all the hospitals in Male. So IGMH, ADK, Hulumale, Vilimale, and Treetop Hospital. So all of them were there, so they've been trained. So in Male, they should be able to screen all babies for critical congenital heart disease before they go home. Before you just send them home and saying, then this is a happy baby. Let's screen and let's check that the baby's heart is also normal before you send them home. And this is what I want you all to learn. This is how you can save a life. You can make a difference. We had an expert consultant from Thailand, and 70 plus doctors and nurses were trained. So in each of the hospitals, they should be able to share the knowledge, and then not. So I hope with this, we all are capable of detecting a baby with critical congenital heart disease, and I hope that this at least made gave you an open eye what is congenital heart disease, how we can save a baby, how we can make a difference as a team. That's it. Thank you. Before I come down, I would like to thank Tiny Hearts of Maldives. This is the 2nd year that I'm doing this. And thank you, Hishko, Mua, and the team. Thank you, Asi, for giving me this opportunity to share this knowledge with the very, very important people, the nurses, who can make a lot of in our community with congenital heart diseases. Thank you.
Understanding CHDs. Next on the agenda is the remarks from the guest of honor. I would like to invite Dr. Shah Mahir, State Minister of Health, to the podium. Thank you.
Bismillah ar-Rahman ar-Rahim. Distinguished guests, all attendees, founder members of Tiny Hearts of Maldives, and all those who are contributing to this program and participating, welcome you all. I'm very honored to be here to take part in this program. And it is also a subject very close to my heart. And as you know, cardiovascular disease is the leading cause of death in many parts of the world and also in Maldives. And a small percentage of that is congenital heart disease. And this is a preventable, and if it can be treated well and detected well, the outcome is very good. And also, the topic is very close to my heart, and because I have my own family gone through a similar situation. I have a brother who is waiting for cardiac transplant, and I also lost a brother at the age of 39 of an MI very recently. So heart disease is very, very important to formulate a good treatment and also detect them early in the newborns. I was very impressed with what you guys have been doing, and it's come to my attention recently, the amount of work that you're doing to contribute in prevention and detection and treatment. So I am very, very impressed, and I can tell you, as in my position as a policy, to influence at a policy level, I totally support, and I will give you my contribution to change things, to take this program forward. So, and also thank you for all the cardiac conditions, and I remember learning them as a medical student long time ago. So it was very refreshing for me to remember those things now. So I think overall, I think we need to strengthen the program, and I hope we can prevent those children having to go to other countries. And I think with the new hospital, I hope that we can retain majority of these patients so that we can treat them in Maldives. So I support that, and I think we need to look into how we can have specialists coming and to support you at your work in IGMH as well. So I think with that, I would say thank you so much for those who are participating in this program, and I will give you my support, and we'll take this forward to not only in Maldives, not only in Mali, also to the islands. And I think that's a very important part that we can play in the health ministry to promote this into the islands. Thank you very much.
Thank you, State Minister of Health, Dr. Shah Mahir. Lastly, we've got vote of thanks by THM Vice Chairperson, Ms. Fatmat Limia.
Good evening, all. I think we've been sitting for quite a long time now. I would like to invite Moa to stretch you all a little bit. Just 30 seconds. So let us all stand up. Actually, Moa, Hishko, and Mai, three of them are good fitness instructors, experts.
So we'll just do a little short one, just 1 minute. Don't worry, we're not going to sweat you. Okay, just stretch your arms forward, keep a few seconds, take like 5 breaths. Deep ones, you feel a little bit relaxed already. Okay, now open your back, open your chest, and look up in the ceiling and breathe. Not the sky, ceiling. Alright, now bring it down, press your head. Back of your head, don't press it, just rest your hand on the head. And relax, breathe. Okay, now extend your arms forward and rotate your wrist. Now the other way around. Okay?
Thank you, Hishko, Moa, and Mai. I won't take that long. I would like to express my utmost gratitude on behalf of Tiny Hearts of Maldives to our State Minister, Dr. Shah Mair, for accepting our invitation and in your busy schedule, taking up some time for this. Sincere appreciation to Faculty of Science, Villa College, for the interest in collaborating with us to move on with this program. I hope the nurses, you had a very good session today. A special thanks to Dr. Elena, who is part of us now, for the continuous support and joining hand in hand with us to make this program a successful one. Your lecture was outstanding. Our dear partners, Universal Foundation and Go Live Maldives, let me assure you that Tiny Hearts Maldives will always work closely with you all, and we thank you for all the support. Thank you all. Good evening. We would like to call Director and Chief Guest, Dr. Shah, on stage because we have something special for you. What? Dr. Asil, please come up. Asma. This is the book that we have made for our Healthy Heart program. This is a program that we do for all the teachers at preschool and primary school level. We have covered quite a few schools now and trained about nearly 146 teachers. So we would like to present this book to State Minister Dr. Shah and Villa College too. Thank you.